Renowned surgeon from UK joining us today, and I'm very pleased to welcome Dr. Richard Packard on behalf of KSOS for sparing his special time to share his wisdom to our members. We welcome you, sir. My sincere thanks to you for accepting our invitation for the talk today. Dr. Packard is a renowned surgeon, well known for his surgical skills as well as his wonderful talks. Most of us might have heard him in his various online webinars as well as the ESERS meetings. He's also famous for operating on the past British Prime Minister Margaret Thatcher, about which he himself is talking. I think he can spare some time at the end to share interesting things about his experience in treating her. We will have an official introduction of our speaker by our moderator, Dr. Vanasri. Dr. Vanasri is Senior Consultant at Giridhar Eye Hospital, Cochin, who will be moderating our session. I welcome you, Dr. Vanasri.
Thank you, sir.
We have our two expert panelists. Both of them are past presidents of KSOS, Dr. S.J. Sai Kumar from Giridhar Eye Hospital, Cochin. Welcome you, sir. And Dr. Arup Chakravarti, sir has also joined. Welcome, Arup, sir. He's joining us from Chakrabarti Eye Care Center, Trivandrum. My special thanks to Arup, sir, for introducing me to Dr. Richard Packard and inviting him on behalf of KSOS for today's talk. I also welcome our president, Dr. Rajiv, sir, and I invite him to say a few words before we hand over the session to our moderator.
Thank you, Dr. Sujit. A very good evening to all of you. It's a privilege to welcome Dr. Richard Packard, a world-renowned cataract surgeon and teacher, to this KSO's International Masterclass. His vast experience and contribution to cataract surgery has benefited thousands of ophthalmologists across the globe. We are grateful to him for sharing his knowledge with us today on two important topics that will help us improve our surgical skill and patient care. On behalf of Kerala Society of Ophthalmic Surgeons, I extend my sincere thanks and warm welcome to Dr. Packard. I also thank our moderator, Dr. Vanasri, and our panelists, Dr. Arup sir and Dr. Sai Kumar, and the scientific committee for making this program possible. We look forward to an excellent learning session. Thank you all. Join us.
Thank you, sir. And now, Dr. Vanasri, please take over and please introduce our speaker and you can start the session.
Sure, sir. Thank you so much. Thank you for having me as a moderator for this session. First, I would begin with formally introducing our today's guest speaker, Dr. Richard Packard. He has had a distinguished career in ophthalmology. He retired as a senior consultant at the Arnott Eye Associates in London in 2022. Before his tenure at the Arnott Eye Associates, he served as a surgeon at the internationally renowned Prince Charles Eye Unit in Windsor, England. He qualified as a doctor in 1970 from the Middlesex Hospital Medical School. Now, following his residency at the Moorfields Eye Hospital, he took on the role of senior registrar at the Charing Cross Hospital in December 1978, working under Eric Arnott, the pioneer who introduced phacoemulsification to Europe. By 1979, Dr. Packard began performing phacoemulsification himself. In 1981, he made a significant contribution to medical literature by publishing the first description of using a folded soft lens in cataract surgery. Throughout his career, Dr. Packard has been dedicated to teaching phaco techniques and has played a vital role in developing new intraocular lenses, phaco machines, and other ophthalmic instruments. His expertise has been shared globally with lectures delivered in over 60 countries. He served on the ESERS board from 1999 to 2007 and has chaired the ESERS video competition judging panel since the year 2000. He is an active member of the Society's education committee and leads the cataract surgery didactic course. His contributions have been recognized with numerous named lectures, including the International Intraocular Implant Club Medal Lecture in 2014, the ESERS Bincost Lecture in 2015, the Frodo and King Khalid Memorial Lectures in 2018, and the UK ISCRS Choice Medical Lecture in 2021. He was honored in 2018 as a guest of the American Society of Cataract and Refractive Surgery. He also co-authored two significant publications with Lucio Burato, the history and evolution of modern cataract surgery in 2019, and the history of refractive surgery in 2020. It's an absolute honor to welcome you, Dr. Packard. And now we would have his first lecture. It is on the intumescent cataract, the white cataracts, and management of the intumescent lens. Over to you, sir.
Hello, my name is Richard Packard, and my talk today will be on intumescent cataract. I have a financial interest in that I'm a consultant to the company Exolens that makes one of the lasers described in this talk. Intumescent cataracts fall into three groups, which relate to the nature of the lens nucleus. First of all, there are the brittle, chalky white nuclei, hard brunescent nuclei, and Morganian small hard nuclei. But one constant between them all is how to create the capsulotomy. In 1999 at ESCRS in Vienna, I gave a presentation on white cataracts. As you will see from the next two slides, the capsulotomy was going to be the major issue. This is what we were faced with then. This is one of my cases trying to do a capsulorhexis, the white cataract, 1996, but it was typical of what was happening at that time. With the white reflex that you get from a lens of this sort, it's almost impossible to see what's going on here. And you can see there's some lens milk coming also. In the end, after having got a certain way with the capsulotomy, I decided that I would need to try and aspirate some of this lens milk. First of all, I'm giving it a wash. Then I'll go in with the irrigation aspiration to suck out some of this material. You can see the nucleus now starting to appear, and as this happens, the edge of the capsulotomy also will become clearer, so that I will be able to complete this capsulotomy. More OVD is going into the eye now. Now I'm going to get the cystotome just to make a single cut here to start the process going again, so we can grasp that edge. And you'll see now that we can tear it round, and there we've got about halfway. You can see up at the top where the tearing edge is, and then that joins up with where I got to before. Not easy. If you use Scheimpflug anterior segment imaging, you can also use this to help diagnose intumescence, and there are certain criteria that make it more likely. An anterior chamber depth of 2 millimeters or less, an anterior chamber angle of less than 40 degrees, lens thickness of greater than 5.5 millimeters, and also the lens shape changing from biconvex on the posterior surface to spheroidal. And we can see this very clearly on the Scheimpflug image on the right here. It's the high intralenticular pressure which causes the problem with the capsulotomy. This is taken from a video made by Virgilio Centurion from Brazil that was presented to the ESCRS video competition in 2006. So in 1999, I recommended the following. Use high molecular weight OVD, be flexible to improve visibility, clear away lens fluid and hyaline cortex, use oblique lighting and high magnification, restart the capsulotomy if required, try the vitrectomy light pipe, use high frequency radiodiathermy, and consider can opener. And above all, take your time. However, at the same meeting, a simple vital stain, trypan blue, was shown to solve the visibility issue. This was described by Gerrit Mellis, but the first person to use this technique was Minas Coroneo while he was working in the outback on Aboriginal eyes in Australia. Here we can see the original Mellis technique with an air bubble using trypan blue to stain the capsule. The dye is then washed out and the eye filled with OVD, which of course makes it much easier now to see what's going on. And this was actually my first eye using the technique with the air bubble. And you can see that we've got a nice capsulotomy now, despite the fact of this intumescent cataract. some countries, trypan blue is not available. Here's a still from a video from Takayuki Akahoshi in Japan. And in Japan, they have to use indocyanin green to achieve the same sort of staining. But trypan blue and ICG certainly helped, but seeing the capsule was only part of the story because of the intralenticular pressure in intumescent cataracts. And we've seen that in the image of the Scheibenflug camera. Problems associated with the intumescent cataract and capsulotomy can be seen very clearly here. This is the video of the original Argentine flag sign. This was in a video that was presented to the video competition of ASCRS and ESCRS. And you'll see what happens in a moment. Capsulotomy is being done with a cystotome, and the pressure inside the lenticular bag was greater than the pressure inside the anterior chamber. The two surgeons who were operating noticed something that they were aware of as far as their flag was concerned. They're from Argentina, and it looked just like an Argentine flag. They were very patriotic, so they saluted this new sign in cataract surgery, and we now know it as the Argentine flag sign. So with intumescent cataracts in the capsule, what are the issues? Visibility of the capsulotomy rim during its creation, overcoming the intralenticular pressure, centration of the capsulotomy on the visual axis, the sizing of the capsulotomy, the circularity of the capsulotomy, the strengths of the capsulotomy. There have been a number of techniques described to overcome this imbalance of pressures. You could do a can opener capsulotomy, overfill the anterior chamber with dispersive or high molecular weight OVD, do a mini rhexis and then spiral it out, puncture and cortex aspiration, high frequency radiodiathermic capsulotomy, preoperative YAG laser anterior capsular puncture, femtosecond laser anterior capsulotomy, and precision pulse capsulotomy. Let's have a look at these in turn. The can opener capsulotomy was what I was doing in 1980, and you can see me doing this here. It worked fine for a white cataract. It obviously didn't give you a continuous curvilinear capsulotomy, but it at least was easy to do if you had a white cataract, and enabled you to have a good opening in the capsule, which was relatively safe. You could just pull out the capsulotomy that you had created. Overfilling the anterior chamber with dispersive or high molecular OVD, we can see this here. First, we stain the capsule. On the left, there will be a dispersive OVD trypan blue exchange. You can see that there. On the right, after washing it out, we're then going to overfill the anterior chamber with high molecular weight OVD, which will attempt to flatten the capsule. Let's have a look now at mini rhexis and spiraling out. What we're going to see here is the creation of a very small central capsulotomy. If you do it on the curve like this, it's unlikely that this is going to tear out to the periphery if it's so close to the center. Now I'm going to pick up the edge and tear it round into about a 3 mm CCC. Next thing to do is to clear away some of the soft lens material. It's being done with a Simcoe cannula. Also want to milk it from the edges towards the center so that there's no pressure inside. Now an oblique cut to enable you to enlarge. When you are enlarging like this, the tear direction is different. You're going to do it in the direction you actually want it to go, rather than as you would make it centripetally with a standard CCC. We gradually take this strip of capsule around until you have achieved a capsulotomy of the size that you actually want. Let's have a look now at puncture and cortex aspiration. It's being done with a 27 gauge needle, and it's important to start sucking as soon as you've gone through the capsule. So we make the puncture, and start to aspirate immediately. And you can see the soft lens material coming towards the opening in the needle. And if you do this, it's very unlikely that this small tear will tear out. What you do need to be aware of when you're creating your capsulotomy in these eyes is that they may well be some fibrous bands. You can see inside the circle on the left that there is an obvious fibrous band there. When this capsulotomy was pulled in the direction it's going at the moment, it tore out. And then what the surgeon had to do was to cut it with a pair of Vanus scissors. Let's have a look now at a difficult capsulotomy with a Morganian cataract. Now, normally you would expect that you would have a good pressure inside the capsular bag to hold the capsule taut. That's not true in this case. So we're injecting the trypan blue into the anterior chamber. We're doing the viscoat exchange with the fluid in the eye. You can see we've deepened the chamber nicely. As soon as we go in here, you'll see lens milk starting to appear, which is going to make it difficult to see what's going on. But again, because we're right in the middle, it shouldn't be too much of a problem. And in fact, you can see the capsule is very slack. You can't really see what's going on at all. So we now aspirate the lens milk. And this, of course, makes the capsule even slacker. You can see those torsional lines. There's no way that with this capsule can actually get it to tear. So the bag has to be repressurized with dispersive OVD. You see that going in now. And once we do that, we can just get it started. And there's enough tension inside the bag now so that you can actually create a tear and complete the capsulotomy as you desire. You see that here. And then we can get on dealing with this very dense nucleus. Here we can see high frequency radiodiathermy. This came in the early 1980s, and it was quite useful until we had trypan blue. This is from a video from Larry Benjamin from that time, and I certainly did a number of white cataracts using this device. The capsulotomy that you get is not as strong as a CCC, but it is stronger than one created using the can opener technique. This is using the YAG laser to create an anterior capsulotomy by multiple puncture. The problem with this is that unless you immediately take the patient to the operating theatre, the soft lens matter swells up very quickly and you get a high rise in pressure. So this is really not done at all now. Here's the femtosecond laser. We all know that you can create the capsulotomy with this, as well as cutting into the lens and creating incisions. And here we can see the capsulotomy being created. It looks amazing, but as we know, there's a significant capital and revenue cost associated with this technology. Precision pulse capsulotomy, you'll see in a moment, is useful with intumescent cataracts. This uses a nitinol ring and an electric shock to the capsule, which is done in a very small period of time, much less than a second. And it creates a fixed capsulotomy. It's available in 5.2 millimeters. So what about the femtosecond laser? We can see we can get a very precise capsulotomy. It's created very quickly and it's surgeon-centered, but there is a release of liquefied cortex as the anterior capsule is breached, and this may prevent creation of a complete free capsulotomy cap. Are there ways to avoid problems, and how often do they occur? Here we can see an attempted flax capsulotomy. You can see the release of lens milk. This obscures the beam, and then what happens is, as we can see top right, there's an incomplete capsular opening which has to be completed manually. But it does end up with a good 360-degree coverage of the IOL. This is a study from Professor Titial in India, and they looked at a number of eyes with white cataracts. Of these, they had one group that was being treated with flax and the other with conventional phacoemulsification. Had 17 with release of milky fluid when the capsulotomy was created in the flax group and 19 in the conventional phacoemulsification group. In the flax cases, with fluid, they had free-floating type 1 capsulotomies in 23.5%. That's 4 out of 17 cases. They needed manual completion of capsulotomy in 13 out of 17 cases, and of these, 9 had microadhesions or type 2 capsulotomy. 4 out of 17 had an incomplete area of capsulotomy of 1 to 2 clock hours, a so-called type 3 capsulotomy. Much less efficient than using this device on a non-intumescent cataract. Here we can see another less than satisfactory result with flax. The eye is docked and you can see the fluid underneath the capsule there. Once the laser is fired, you'll see what happens. There will be a release of the lens milk. There we go, boing. And this will prevent the capsulotomy from being created as you would normally expect. It'll be easier to see it in a moment under slow motion. You can see what's happening here. There's a release of this opaque fluid, which of course will prevent the capsulotomy from being the way we'd want it to be. Here we can see that with staining it's incomplete and it will have to be finished with a manual approach. Burkhard Dick in Germany has devised a method of creating a 2 mm mini capsulotomy with a femtosecond laser to release the intralenticular pressure. They then remove the milky liquid that spills out without causing any harm to the anterior chamber. Next, the laser is redocked on the patient's eye. Then a second 4.5 to 5 mm size capsulotomy is created. All the cases using this two-step approach had good quality capsulotomies with 360-degree overlap of the IOL optic. Zhu in China compared manual and femtocapsular complications in white cataracts. Their study comprised 132 eyes of 132 patients, 66 in each group. Anterior capsule tears were significantly more common in the manual group than the flax group, 12.1% versus 0%. All 8 cases, the anterior capsular tears were intumescent. 6 flax cases developed incomplete capsulotomies, 4 of which were intumescent. So again, they had to be completed manually. Laser capsulotomies were better sized and more circular, and the IOLs were better centered than the manual CCC group, as you would expect. What's surprising is that all the white cataract cases in which femto was used, shown on YouTube, required trypan blue to see if the capsulotomy was actually complete. PPC, precision pulse capsulotomy, provides a method without dye. We see that here. Push this into the eye, allow the suction to attach it to the anterior capsule. This is done by the nurse withdrawing from on the syringe. It's fired and you can see how much lens milk comes forward when it's removed. What's interesting here is that the capsulotomy and lens do not appear to be centered in the pupil, but they are on the first peak and J reflex, indicating that this is actually, the lens is actually centered on the visual axis. SLC is carried out with capsule laser. The laser is mounted on the underneath of the operating microscope and it can be slid out of the way when it's no longer required. As you can see, there's a small console for size selection. How does selective laser capsulotomy work? There is absorption of the orange wavelength 590 nanometers of laser energy onto a trypan blue stained capsule. This converts type 4 collagen to amorphous collagen. The triple helix of collagen undergoes thermal unwinding due to disruption of the hydrogen bonds, allowing shrinkage. And you can see here the difference in the structure between type 4 collagen, which is very regular, and amorphous collagen, which is quite the opposite. The capsulotomy edge is rolled over and hence it's very smooth. And you can see amorphous collagen at high magnification on these EM photographs. As far as capsular visibility is concerned, we use a microfiltered 0.4% trypan blue, and this gives an intense capsular stain. In order to overcome intralenticular pressure, overfill the anterior chamber with an OVD to flatten the capsule. This is best done with a high molecular weight OVD like 2% sodium hyaluronate. We have noticed that in greater than 98% of patients over the age of 50, there is an enhanced area of staining, which we call the trypan capsular landmark, and it is coincidence with the coaxial Purkinje reflex, and you can see 6 examples of this here. You can use this for centration, and here we can see the aiming beam of the laser on the trypan capsular landmark prior to firing the laser. What's interesting is that if you use the focusing device here, you can see on the left there is no lens line reflections, and this is present when you have an intumescent cataract compared with a standard cataract. When you center the capsulotomy, as we've seen, you end up with 360-degree symmetrical coverage of the intraocular lens optics, and this is very important for premium and capsulotomy fixated IOLs. As far as capsulotomy sizing is concerned, using the console that you can see here, the size can be increased by 0.1 mm steps from 4 to 5.5 mm, and shortly this will be extended to 6.5 mm. Circularity is important in a capsulotomy because it will even up the tensions at its edge so that any capsular contraction will be completely symmetrical. We carried out a study using paired cadaver eyes to compare the strength, the edge strength of SLC with other modalities of creating capsulotomy. So CCC was compared with capsule laser and with flax, capsule laser was compared with flax, and CCC was compared with flax. The smooth rolled over edge of amorphic collagen gave increased tear strength. This study was reported in the British Journal of Ophthalmology in 2019, and if you look at the relative tear strength, if CCC is 100%, flax is 70%, and capsule laser is 150%. And this is significant, P less than 0.01. In all of the intumescent cataracts that have been operated on using capsule laser for selective laser capsulotomy, there have been no Argentinian flag signs. Here are pictures using the anterior OCT to demonstrate intumescence for the study. You can see the fluid areas within the lens. And here we will see a selection of SLCs in intumescent cataracts. What's surprising about this is the shrinkage which takes place in the capsulotomy cap relative to the increase in size of the capsulotomy which is created, indicating the degree of intralenticular pressure within this cataract. Here are some post-op pictures. On the left at day 1, you can see there's good symmetry of the capsular opening on the IOL, and in 1 month it's exactly the same, which demonstrates how well this capsulotomy has been created. In summary, the intumescent cataract can present real challenges, particularly creating a capsulotomy. You need to be able to recognize the cataract being intumescent, which is helped significantly by anterior segment imaging. Note the consistency of the nucleus, whether it's a brittle white, renescent or Margagnian. Stain the capsule with trypan blue. Use high molecular weight OVD and overfill the anterior chamber. Consider puncture and aspirate, minirexis and enlarge, and watch out for fibrous bands. Or consider the use of an automated device like PPC or SLC. We believe that SLC with capsule laser provides a better approach for the intumescent cataract. A pressurized AC with a high molecular weight OVD will help to avoid the Argentinian flag sign. Microfiltered trypan blue is used to identify the anterior capsule and its landmarks as we've discussed. The trypan capsule landmark is there to identify the visual axis when the patient can't fixate. And laser capsulotomy with a consistent size, circularity, and a strong elastic edge in less than 0.3 of a second is available. You get 360-degree IRL coverage due to well-centered capsulotomy, and this assists in PCO prevention because of it being symmetrical. There's also easy identification of the capsular edge during nuclear removal and lens implantation. Thank you very much for your attention.
Thank you, sir. I think that was an excellent coverage of the Intumescent capsule and the wide cataract, and right from the history of many years of how things went right in the beginning. You have so beautifully covered over the years and so many techniques by different surgeons, different techniques that can be used to deal with the intumescent cataract and the Argentine flag sign. So as you said in the end that your preferred technique is the laser the capsule laser for creating the capsule access in the intumescent cataracts. But many of us are not having that liberty to have that machine. So what I would like to ask you is, what would be your second best preference? Would it be flax or would it be?
No, I don't think flax actually is indicated here at all, because the problem is that if it's a true intumescent cataract, when you hit the capsule with flax, you get that puff of lens milk and you get an incomplete capsulotomy. So I think
Right.
that the studies I've shown here show that this is not the best way to go. You can use PPC, Zepto. This will work for you, and it's certainly less expensive than using the laser. But the advantage of the laser is that because of the trypan central landmark, you can actually get the visual axis, and you can't do that by any other means. Now, obviously, in an ideal world, you'd all have a laser like this, because I believe it is the best way to do it. But I think there are also tricks that you can use, which I have shown you some of. I mean, like Dr. Arap using the mini Rexis in his video to create that. Because the thing is, if you stay right in the middle, it's not going to tear out, particularly if you've created a little curve. If it's a straight cut in the anterior capsule, then it is at risk because of the pressure of just doing that. However, if you make it a little bit on the curve, it's not likely to do that, which is why you're able to create the mini Rexis. The other alternative, which I've certainly used, is Ronier's technique, where you go straight in and suck immediately to get the pressure out of there. But I think that needs to be done also in conjunction with the use of a high molecular weight OVD like Helon 5. You can't do it with HPMC. It doesn't work because it comes out of the eye far too easily. And you'll still end up with a convex anterior capsule. And it's the convex anterior capsule which is really the issue here, because if you don't get it flattened, then the tear just goes down the slope, and there's nothing you can do about that.
Right, sir. So, Dr. Arup, can I have your comments on your preferred technique and what would you recommend to the young surgeons?
Yeah, I think I would fully agree to what Dr. Richard Packard has said. Zepto came to India with a lot of fanfare a couple of years back, but then it went away. That wave just vanished. And then I am told that there is a distributor in India who is who is trying to market capsule laser. One or two places where they brought it for trial. So I think
they've actually they've acquired some now. Arab.
Yeah, someplace in Pune, I think. Someone
Yes,
I don't know
Pune,
whether.
right.
Yeah.
I think in Netradhama also they are using capsule laser.
Yeah, there's about
I've
half
seen
a
some
dozen
videos.
places now that
Yeah.
have the.
So I think capsule laser, if it is not going to be as the thing with the Zepto was it was costing at least 10 to 15,000 rupees per cases, which itself was in the Indian scenario where you have most of these intumescent cataracts patients really come from backward financially backward communities, so they find it difficult to afford. I wonder how it is priced in Europe, Richard, your capsule laser.
Well, there are various ways of financing it. You can do it on a capex basis, whereby you buy the laser and then you pay a small amount per case, which is essentially for the dye, which is a patented dye. You can't use Aura Blue; it won't work. Apart from anything else, Aura Blue is filled with monoazo impurities, so you shouldn't be using it anyway. But the dye that we use is a microfiltered 0.4% solution. whereas the standard trypan blues are 0.06%. The 0.4% will give you a much stronger staining and also will enable you to have the central landmark as well. The cost is relatively low. You do need to use a better OVD. You can't use HPMC with this. It isn't optically clear enough for the laser to work. But it's certainly, if you're using it for premium patients, it has the advantage, if you are putting in a multifocal or EDOF lens, that you know you're going to be able to get that lens on the visual axis and also have symmetrical coverage of the IOL optic, so that the onset of PCO is very much diminished.
Richard, in the context of the centration of the rexis, I mean, would you like to center the rexis on the limbus or on the Purkinje image? Because
No,
at the end of the day, whatever the rexis is located, lens is centered on the equator, on the capsular equator. So basically, an angle alpha comes into the picture. So we
indeed.
may think that we are centering the rexis on the visual axis, but ultimately it may not be what is happening in the postoperative period.
Well, our experience, and we've done a big study which was published in JCRS, looking at centration methods, comparing the Purkinje image and the trypan central landmark, and also centering it on the dilated pupil. And the centering on the dilated pupil gives a less good vision. And also, you do not get symmetrical coverage of the IOL optic. With the other two methods, you get symmetrical coverage, 360 degrees of the IOL optic, and also you're on the visual axis, and we found the unaided vision was actually better in those two arms of the study.
Okay.
Yeah.
Dr. Sai Kumar wanted to raise a point, sir.
Yeah, just the capsule laser is available in India. In fact, I think it's marketed by My Healthscape. They had actually approached us for a trial, and again, as Dr. Richard said, they charge for the dye, so it is a per case basis. It actually doesn't work out to be as expensive as the femto at all. It's actually much cheaper. I saw the videos, and I saw the outer rim of the rexis sort of moving away from the original rexis, creating a gap there. I don't know. I was a bit scared on seeing that. So I think I have now more confidence probably to try it out after seeing your videos, sir, and the fact that you have shown that it is much stronger. Because otherwise the way the capsule splits and the outer rim just moves away, I was sort of wondering whether it'll just break away.
Well, to date, over 45,000 eyes have been treated with capsule laser across the world. And what you're noticing when you say that this split is occurring, this is just a function of the elasticity of the capsular bag. And it's more extreme in an intumescent cataract because there's more intralenticular pressure. So it's putting more stretch on the anterior capsule. So inevitably, when you get the excursion of the laser, which is so quick that nothing much can happen, you see that the capsular cap actually shrinks, but the opening expands. By the same token, it contracts again when you've taken the cataract out and the soft lens matter has gone. When you put the lens back inside the eye, the IOL, it expands again because you're putting some bulk inside the capsular bag.
And just one comment which I had to make about the intumescent cataracts with my experience is that when you make your first nick, if fluid comes out, you're actually safe. Okay, so part of your intralenticular pressure is coming down, and then with the judicious use of OVD, of course, with the stained capsule, you can make a mini rexis like what Dr. Aroop's video was there, and then enlarge it again after washing out the superficial cortex. The problems occur in cases where you make the nick, there's no fluid egress. So you have these, very intumescent fibers of the anterior, cortical fibers, which are just sitting there. In spite of your nick, there is no reduction in intralenticular pressure. And those are the capsules which are more likely to, to extend, to go into the Argentine flags and things like that. So in such situations, the using a 27 gauge needle to aspirate, makes a lot of sense. That's what I feel. And in the Morgagnon cataracts, actually, the rexis, although you have trouble in making the rexis usually does not extend, because
No,
the
it doesn't.
moment you
Right.
touch, all your intralenticular fluid comes out. The rexis does not extend at all. Of course, Morgagnon cataracts have other problems, like some of them have weak zonules. Even the video that you showed, there was so much of wrinkling of the anterior capsule. The zonules may be weak. You might find it very difficult to take out that small but hard nucleus from inside the bag. It keeps on rotating. There is no epinuclear cushion for that. So those are the problems with the Morgagnon cataracts. But once you have fluid leaking out, I feel that the rexis can be completed safely.
Yeah, I mean, I think the interesting thing here is we all know that there are lots of methods whereby you can get around this. But if you look at the published series, there is not one single published series of dealing with the capsulotomy manually that doesn't have some tear-outs. The study that we have just had accepted for JCRS of 93 intumescent eyes, all of which we demonstrated intumescence with the Anterion OCT, none of them did it. It was 100% success in terms of creating a capsulotomy without a rim tear out. And I just thought that was impressive.
Yeah, coming back to the same point on the capsular puncture and aspiration. So I get a feeling that before you start the aspiration, as soon as you puncture the anterior capsule, and if there is a lot of stress on the capsule, it is going to give way. Because for you to start aspirating, you have to puncture the anterior capsule and get into the subcapsular zone. So if the capsule is really stretched out, that the first act of capsular puncture, is going to take the opening to the periphery, giving an Argentine flag. On the other hand, if you make the first puncture and it doesn't go out, and then subsequently it goes out, I feel it is nitrogenic. This was a rexis which should not have gone to the periphery, because most of the time the aspiration and the puncture, they're not simultaneous. The cystitome, the needle is not connected to a suction apparatus, and we don't go in aspirating and puncturing at the same time. So first the puncture happens, and then aspiration starts. So I used to do it quite often earlier, but then I found out that some of those real challenging cases. Let me give an example. Younger patients with silicone oil, post-vitrectomy cataracts with silicone oil in the posterior chamber, the first puncture that you make, it goes to the periphery. There is you don't get any second chance of aspirating or retrieving the rexis opening in any way. But I think, still, one could try out aspiration of the cortical material after puncture, but I've given it up because I find that, it is perhaps not really that effective. It makes sense, okay, you're aspirating the high pressure areas under the capsule, but then we must remember that high pressure areas that under the capsule are not just not under the needle. There are different pockets, different locules. They could be present in the periphery. They could be present behind the nucleus. So even if you manage to decompress one particular high pressure locule, how sure are you that you have decompressed the rest of the areas where high pressure could exist?
Barry, you're absolutely right. If you look at the OCTs, in one of the slides, you could see there were little pockets all over the place of the fluid. It wasn't one particular single lake. And you're absolutely right. So this is why often you actually have to milk from the sides to avoid having an extension, because you may just taken out a very small amount of the liquid, which wouldn't be enough to get rid of the pressure that is pushing on the capsule.
I would like to add 2 points for the young surgeons. One, I would say, when you go in if you're made of mini rexis and if you're extending the rexis, try to use the smallest gauge of microrexis forceps and needle that you can get your hands on, because the larger your side port, the more is the leakage of the viscoelastic, and the young surgeons are not aware that the viscoelastic is flowing out because they are slow in their movements. So try and use the smallest gauge possible and try to make the side ports a little small. And I would say one more thing is be prepared if there is a rexis extension, how you're going to manage it ahead. Make a plan beforehand how it is going to be done. If you're not able to do it, at least keep a senior standby to guide you. Or if you're confident enough to go ahead, make a plan. In case of a rexus extension, how do you manage the case? Do we have any more questions from the participants who are here? If anybody would like to raise a question? I guess not. So can we go to the next topic?
Ankit, you can play the second one.
Flow, force, finesse. The art and science of Phacodynamics. I have no financial interest in this talk.
In 1970, when Charles Kelman, the inventor of phacoemulsification, gave his first teaching course, he had worked out the basic dynamics of phacolens removal.
This is a hard, senile cataract being emulsified and withdrawn through a small 2mm incision. The reduced hospitalization and recuperation time are made possible by a new surgical technique which fragments, dissolves, and emulsifies the cataract and then aspirates the remnants through its own needle. This instrument is the phacoemulsifier. The handpiece is lightweight and maneuverable. The working tip consists of a hollow titanium needle surrounded by a silicone sleeve. The tip is moving at 40,000 cycles per second, and saline flows between the titanium needle and the sleeve. Aspiration is effected through the center of the needle, and the amount of material aspirated from the eye is exactly replaced by the flow of saline into the eye. A foot switch controls the operation.
There you have it. In 1970, Charlie had worked out most of these things. But in order for phaco machines to work, we need to understand what the phaco parameters are. The foot of pedal position is important from 0 through to 3. The irrigation fluid delivery, the aspiration flow rate, vacuum, the phaco power, and also something that people tend to forget about, tip configuration. And each of these parameters represents a surgical tool which, when adjusted, can aid your surgery, or not, as we can see here. Yes, a botched attempt is correct, but can anyone suggest a more family-friendly way of describing what happened to the poor patient? The function of any one of these parameters interrelates with and affects the others, and individual settings for each surgeon will relate to their experience, the type of technique that they're using, and also the machines that they're using. There are two basic types of pumps available on phaco machines, peristaltic and venturi. Peristaltic pumps work by pinching tubing between rotating rollers, as we can see here, and aliquots of fluid are gradually moved through the system. Venturi pumps work by passing compressed gas across a tube opening, which creates a pressure differential, and this in turn produces vacuum in the attached vessel. On these widely used machines, there are peristaltic pumps. We go from the Centurion, the Bausch & Lomb Stellaris. Most people don't know they have a peristaltic pump. The J&J Veritas and the Arclifaros. On the Stellaris, you can also change to a Venturi pump, and most people do. On the Veritas, you can swap between the two sorts of pump in mid-case. There's a new pump now, the Quattro, which is available on the new Zeiss Catera 700 machine. And this has a synchronization of inflow and outflow to minimize surge with input and output centers. The reason we want all this is because from our machines we want to get a stable anterior chamber of comfortable depth, and if possible a constant positive intraocular pressure. We try to achieve this by constant infusion pressure, as I've said, gravity feed determined by bottle height, or it could be gas-forced infusion into the irrigation bottle, or active fluidics due to irrigation bag compression, or inflow and outflow monitoring by synchronization. You also need to reckon about leakage, because you want to have zero or minimal leakage, and this will be determined by wound size in relation to the tip and the sleeve size, and also, most importantly, the loss from the side port. Controlling outflow due to aspiration and vacuum to avoid chamber instability is really important here. So how do we set the infusion pressure? First of all, passively. Just remember that in full tip occlusion with no outflow, it is the bottle height which will control the intraocular pressure. Many machines are preset to 65 centimeters. This is not really high enough for use with very high vacuum, and I generally advise 110 centimeters, but remember that this is the equal to 80 millimeters of mercury in the eye when there is no outflow. The important thing is that the infusion needs to be high enough to at least offset total outflow from the eye. Let's have a look at infusion active. With gas-forced infusion into the irrigation bottle, this leads to high intraocular pressures but stable chambers, as on the Bausch & Lomb Stellaris Elite, the J&J Veritas, the Opticon R Evolution CR, and the Dork Eva. Active fluidics, as on the Alcon Centurion, controls the intraocular pressure at a surgeon-chosen level, which may be nearer to the physiological level, and this is done by compressing the irrigation bottle between paddles. The Centurion has a sensor in the active Sentry handpiece, which means that this is to try and minimize the IOP chambers at occlusion break, and by having the sensor much closer to the action, the response time can be much quicker. If you compare IOP change between various irrigation approaches, we can see what happens on the left here between the active fluidics and gravity fluidics. And once you get to a certain point with aspiration flow rate, the control of the intraocular pressure drops away and the pressure becomes too low for the chamber to remain stable. With pressurized irrigation, you can certainly keep up the IOP, and it does drop away as you use the pump, but it certainly does vary. But it does mean overall that there is a high intraocular pressure. On the Cataract 700, input and output are synchronized. You can see this in the graphic here, so that there should be minimal loss of fluid within the anterior chamber, regardless of what the phaco machine is actually doing. It means that there is a 200 millisecond change from free flow state to returning to the intraocular pressure before the occlusion break. So it's very quick indeed. When do you want to change the irrigation input? Well, you want to put it up to deepen the anterior chamber. If the incision is leakage too much, if aspiration and vacuum levels cause chamber shallowing, put it down when there's a capsular break, particularly during vitrectomy, and also when the anterior chamber is too deep, as it might be in a highly myopic eye. Aspiration flow rate is measured in cc's per minute, and it is a function of peristaltic pump speed. Aspiration flow rate affects the time to reach preset vacuum level, which effectively means tissue followability. You can see this here in the two pictures on the right, where you have a flow rate of 40 cc's per minute. It only takes half a second to reach a vacuum of 200. On the other hand, when you have a flow rate of only 15 cc's per minute, with this particular old machine, it could take 6.5 seconds to reach the same vacuum level. On occlusion in many machines, the rate of flow can actually be increased or decreased depending on the state of the operation and the experience of the surgeon. Aspiration flow depends on certain things: the tip configuration, whether it's narrow or curved or flared, the stage of the operation, whether you're sculpting or trying to remove chopped up or broken segments of nucleus, the phaco technique you're using, either chopping or divide and conquer, how experienced the surgeon is. More experienced surgeon will probably get things going faster, the type of cataract, whether it's a soft or a hard cataract, and also the fluidics capabilities of your machine. Modern machines can use a much higher flow rate safely. And or not whether there is occlusion, because with occlusion on a peristaltic pump, the flow settings will gradually disappear. So when do you want to increase the aspiration flow rate? To speed vacuum rise time, as in chopping techniques, to overcome a narrow lumen phaco needle, and to improve followability of tissue. When do you decrease the flow? With softer cataracts, to prevent the rapid passage of the phaco tip through the nucleus, or vice versa, to remove epinucleus because it's friable and will just break away otherwise, With a capsular rupture to prevent aspiration of vitreous, you also lower the bottle and the vacuum. Let's have a look at vacuum now. Vacuum refers to the negative pressure in millimeters of mercury at the aspiration port. You can see the measurement here. Certain properties. It's for holding lens material while the tip is occluded. At higher vacuum levels, this will reduce clogging in the phaco needle, and it also means that you can remove nuclear material without using ultrasound, which is obviously better for the eye. There are disadvantages of excess vacuum, namely surge.
When the occlusion breaks, there is a sudden increase in outflow that creates a void of fluid in the anterior chamber. The inflow line dynamically compensates this void by replacing the fluid that is being removed. The delay between the outflow increase and the inflow compensation creates the transient shallowing of the anterior chamber known as post-occlusion surge.
How do we actually get occlusion break surge? Well, if you imagine the phaco needle with unobstructed flow, you then get full occlusion, and the aspiration tubing, certainly in the form. At occlusion break, the exact opposite happens. The tubing expands, the gas bubbles contract, and this pulls fluid from the anterior chamber, and thus you get the occlusion break. However, with modern machines, there is reduced compliance in the system with much stiffer aspiration tubing and rigid cassettes, and this has a very useful effect in limiting the effect of surge. With all pumps, vacuum is preset to a chosen maximum, and this will depend on the stage of the operation, whether you're sculpting or removing bits of nucleus. Here we can see this. The type of cataract, whether it's hard or soft, as we've seen, and also the phaco method in use, whether it's divide and conquer or a chopping technique. With peristaltic pumps, vacuum only starts to build when the tip is occluded, and we've seen these pictures already. We know that pump speed equals the rise time to preset vacuum. Venturi pumps have variable flow because flow and vacuum are interrelated. You can't separate them. And they also have active tip vacuum. It is present without occlusion, which certainly improves the followability of piece of nucleus to the phaco tip. When would you want a lower vacuum? The chamber which is unstable, with a shallow anterior chamber as in a short eye, and always when you have a capsular break so that you don't suck things up that you don't want to. Now let's look at ultrasonic power. This consists of the mechanical impact of the tip, the acoustic shock wave, the impact of the fluid particle wave, cavitation, and tip movement. But also remember about heat generation at the phaco tip. Cavitation is talked about very much, but in fact, by far the most important thing that the phaco tip does is the mechanical impact. With softer cataracts, you can actually see the acoustic shock wave and you can remove tissue without actually touching it. Let's have a look at what cavitation does. There is an implosion of bubbles that are created by the phaco tip and a significant release of energy, which is why you want to reduce cavitation if you possibly can. But just remember, there's an important concept that when you change power, the only thing that alters is the stroke amplitude, never the frequency. If you push up the power, you get an increase in heat. There's also an increased resistance to flow and a greater energy dispersion in the eye, which leads to the release of free radicals. And it is the release of free radicals that causes the change in the cornea when you look at it on day one after surgery. But too little power is also bad because it stresses zonules in the capsule. So remember to push with your foot, not with your hand or your phaco tip. It's particularly true with harder cataracts. And remember also that efficient phacoemulsification needs power, vacuum and flow to interact effectively. Let's have a look now at traditional phaco power modes. When I first started phaco in 1979, we had panel only, with a preset fixed duty cycle of 100%. In 1981, the first machine which had a linear phaco was available, which was a big improvement, but again, it was 100% duty cycle. Then we got pulsed linear phaco, which had a frequency of 50% duty cycle, and then burst, where there was panel power but increasingly frequency until you got to continuous. Then when the Allergan Sovereign machine came along, we had hyper or micropulsing, where there was a linear variability of the pulse width and also the variable duty cycle. On the Infinity Phaco, we also got microburst, which was a combination of burst and micropulse, where you got a linear burst with a variable pulse width, but also a maximum frequency pulse at maximum power, so that you could gradually increase up to a certain frequency. Why do we need phaco tips to deliver this? They deliver energy by rapid movement of the tip using piezoelectric crystals for current switching. And this is what disrupts nuclear material, to allow this to be removed from the eye through the lumen of the phaco needle. Here are some examples, and we can see variation by size and shape. In the top row, we go from 19 gauge through to 22 gauge. Down on the left, you can see a difference in shape, curvature, and internal diameter, and also restricted internal architecture. And also you can see something like the balance tip, which has got a compound curve to create a better performance by the phaco tip. Angulation and position of bevel is important. The majority of phaco tips have a bevel up, 30, 45, or even 53 degrees. You can also get a 0 degree with no bevel, and a bevel down, which is normally 30 degrees, and some people who chop prefer this. There are also blunt phaco tips available. The Dewey radius tip, which is supposed to protect you from breaking the capsule with a phaco tip, as does the Aquahosho knuckle tip and the Intrepid hybrid tip. And why are these important? For fluidic settings, for the efficiency of cutting, for requirements of specific energy delivery, requirements also for different nuclear removal techniques, and to avoid tip clogging by nuclear material, and also to assist in surge control. And some tips also have the ability to assist in cooling. And since we now have reduced incisions, you need narrower needles to go through these reduced incisions. So what determines the settings for any given phaco tip for fluidics? The amount of irrigation fluid entering the eye, leakage from the eye, the internal diameter of the tip at its narrowest point, and this is described by Poiseuille's law, and in this, r to the power of 4 indicates how important the radius of the tip is. When you change it, it makes a big difference to the way that the internal diameter affects things. The presence of built-in leakage in the tip, the aspiration bypass system on tips on the Alcon Centurion Infinity, which helps with cooling. Aspiration tubing compliance we've talked about already. This is now very stiff on the Alcon Centurion, the JNG Veritas, and the Quatera 700. And also any resistance in the path of the pump, to the pump, where stable chamber tubing, as on the Bausch & Lomb Stellaris, can make a difference. Let's have a look at the effect of different tips on phaco tubing and also occlusion break. At the top, if you move from the 1.1 tip with standard cassette on the old 20,000 Legacy to the more stiffer tip, you can see that the amount of vacuum that you can safely use and flow rate goes up considerably. And as you move down the different tip diameters, you can get more and more vacuum, although you do actually need this because of the greater resistance in the phaco tip.
A cavitation halo appears as a crown surrounding the rim of the round 30-degree tip. We observe no cavitation bubbles projecting away from the tip of the phaco needle. All cavitation occurs during the retraction phase of the motion cycle and above 60% ultrasonic power. The Kelman tip shows particular characteristics. Cavitation bubbles are seen on the posterior surface on projection of the tip and on the anterior surface on retraction of the tip. Also, the needle bends on each cycle, showing a lateral displacement of the tip rim covering a wider area. Tissue contact produces emulsification at low powers, like if a spoon was removing material due to the mentioned lateral displacement.
Also, the requirements for specific energy delivery. So here we can see torsional movement of ozol as originally seen on the Alcon Infinity, and this needs some curve in the tip. Ellipse is said to work with both straight and curved tips, has now been upgraded to the Ellipse FX, which has a slightly higher frequency of 38 kilohertz. I personally think it works better with a curved needle rather than a straight one.
There is now another tip movement on the Alcon Unity, 4D Phaco it's called. It's supposed to be able to remove the nucleus faster with less energy, and it moves as an entirely different way, so-called multi-directional ultrasonic motion, and this creates a rapid volumetric cutting pattern.
So how are we going to choose? Because tips come in many shapes and sizes, as we've seen, and the list we've had here is by no means exhaustive. But you do need to match the right tip to the job in hand, and the machine that you use is crucial. Understanding the Phacodynamics for each tip is critical for most efficient energy on your surgery. So in conclusion, even though cataract surgery may be moving on, with the introduction of laser assistance, an understanding of Phacodynamics is essential to make us better, safer surgeons. Thank you very much for your attention.
I think, so it's an excellent coverage of Phacodynamics, right from the entry of the fluid to the egress and the phaco power that is being used. Again, for a young surgeon, it is a confusing scenario where we read the theory about the whole thing, but when they actually start operating on the eye, a young surgeon is always confused about how and what their settings should be. So do you recommend the surgeon should follow his mentor's setting or try to learn setting up his own comfortable settings right from the beginning?
When I still had residents under me in Windsor, we actually had a resident setting that we used, which was less aggressive than the settings that more senior surgeons would use. Essentially, that was a little bit less vacuum, a little bit less of the aspiration flow rate. But I think the important thing for trainees is to go through the machine with the company representative and get them to understand what the different parameters are, possibly to go and see a lecture the like of which you just had now. There are actually good books on the subject. Barry Seibel's book on Phacodynamics is excellent, and it explains in simple diagrams how it all works and what the difference is between how you would set up for a peristaltic pump and a venturi pump, and what the effects of the different changes are. Yes, it can be confusing, but if you start off with a simple, straightforward approach, it shouldn't be too bad. The other thing that of course is a big advantage now is that phaco machines are dramatically better than they were when I started doing phaco. When I started, the first machine that I used was a Cavitron Kelman's 8000V, and the settings that we used were an aspiration flow rate of 25 cc's a minute and a vacuum of 47 millimeters of mercury. Don't ask me why, but that's what we used. And if you had a higher vacuum than that, you'd find your chamber instability would just make things unpleasant. The sight machine, which was one of the early machines, had a diaphragmatic pump, and the anterior chamber used to go up and down like this all the time. It was horrible to use. I think that the young now don't realize how lucky they are that the machines get better and better and better. I'm told that the new machine from Alcon, the Unity, has extraordinary characteristics as far as the lack of surge is concerned, so that to some extent you can use higher vacuums and flow rates now with safety, because the machine is doing so much more for you.
Absolutely, sir. So can I have some comments for Dr. regarding the fluidics on his settings? Dr. Sai Kumar, can we have some comments from you?
Yeah, see,
Yeah.
regarding
Yes,
the settings for a beginner, see, I don't think a surgeon, a neophyte who starts phaco, is all alone in the operation theater.
No,
he
quite
is
right.
invariably, suppose is assisted by a mentor. And the mentor definitely knows what are the, safe parameters for the young surgeon to start off with. So I think instead of, using the company set parameters, it is always better to have your mentor at the side, and then he who sets up a safe parameter according to his experience and the behavior of the machine. And then once the surgeon has learned the basics, then he can, switch over to whatever he wants, high vacuum or high flow or slow-mo phaco. So that is the time where he can, start exercising his wisdom and his newfound wisdom and his, acquired knowledge. But to start off, he definitely needs to have a set of parameters which
Absolutely,
can
sir.
be easily, transmitted by the mentor. Sometimes, you have the company engineers,
The
but some
mentor.
of these company engineers, who come for with the machine, they just install and they have no idea. So they say they were to get the application engineers, and the application engineers have to come. So it becomes more complicated. But I think it is necessary to have, this set of people helping someone out, helping a new beginner out.
So
Yeah, it's
Yeah,
interesting.
So there are various
Yeah.
stages. Someone who's learning phaco right in the beginning, somebody who's had an experience of 100 cases, somebody is at 1,000 cases. What I have noticed is many a times people get stuck with one setting that they have learned, and they don't move ahead to, change the settings what will suit them. So my point is actually to surgeons who have progressed from say 100 to 500 cases, 1,000 cases. Now is the time you need to learn the practical aspect of fluidics, get in that engineer, ask him to change settings a little bit here and there so that you are more comfortable rather than sticking to the one particular setting that you have always used probably in your training.
No,
Well, you're
as
Dr. Sai.
Richard was just mentioned,
Yeah.
yes, I.
No, just 2 points because I do train quite a lot of fellows in my hospital. So 2 things which, of course, I stay with them for the initial maybe 30, 40 cases. So one is to always have the continuous infusion on, because when you start, doing your phaco, sometimes when you come out, you take your foot off the pedal, the chamber collapses. So always have your continuous infusion on when you do your initial cases. And second thing is, like Dr. Richard Packard said, don't push the nucleus. You have the adequate phaco power. Don't be scared. If you have a grade 2 or a grade 3 nucleus, don't stay at very minimal phaco power just because you are a beginner. It doesn't work that way. So you finally end up pushing the nucleus, and creating more problem with the zonules. So having the right power, the right fluidics is very important. And like Dr. Arup said, the mentor settings should be the initial settings for the initial maybe 50, 100 cases, and then they can make their own way of setting. But having the infusion always on when they are doing makes a huge difference in my training, at least.
Yeah, I mean, you're right. One of the things that I've set on the Alcon machines is that you can set it up so that when the foot pedal goes into position 3, when the phaco starts, it's not at 0. You want to start, particularly if you're using torsional phaco, you want to start the junior doctor at about 30% and go up to 60 to 70%. Because what that means is that they're going to get some effect the moment they get into phaco, and they're not going to be pushing that nucleus away from them. The other thing about people not changing their settings, I remember I was lecturing some theatre nurses many years ago, and I was talking about the machine and so on and so forth. And I asked the question of them, how many of their surgeons had actually changed settings on the machine since the company representative had come to install the machine? Not one hand went up. They had all stayed exactly the same. And you're quite right. People get into a rut and they don't actually look and analyze what they're doing and why they might want to change, because there are capabilities in the machine they're not even aware of.
You're quite right, Richard. I mean, it is a couple of years back, I was there in a life surgery session. I was in the panel. So I saw a surgeon using a high-end phaco machine. He did the divide and conquer technique. He didn't change the the parameter settings right from the beginning to the end. So I knew this boy pretty well. So at the end of the day, I asked him, I mean, how come you're sculpting, you're chopping, and fragment consumption with the same parameters? Plus, sir, I have been I mean, it doesn't make any difference. By changing the new machines have become so forgiving compared with older machines. That even the surge control and wound burn, everything has become sort of quite uncommon. Like when I learned in about 1993, Richard, that was an OMS modular machine, and it a heavy handpiece and unit.
Remember
Then
it well, yes.
yeah, then universal 1, 2, and like that. So at that time, there are not much of controls. Everything was fluidics. You had only few settings. You had just 3, 4 settings, and then you played around with the pulse mode, burst mode, and when the AMO people came up, allergen, it was allergen. So that we had an opportunity to experiment with the various parameters as we grew and as the new machines started coming. The newer machines have become so sophisticated, like as Richard was mentioning his talk, with the surge control mechanisms and the thermal burn control, I mean, what are the various active centers and things like that. So I think, there is lesser margin for more margin for error in these situations. So there are less complications. But, I mean, you have to have, an idea as to what is the given situation and what are the parameter settings that are need to be, made to make the process safer and more efficient.
Yeah, indeed, absolutely. But you'd be surprised actually how many senior surgeons know very little about fluidics. I was teaching a course many years ago with Brian Little and David Allen in the UK, and these were supposedly senior surgeons. It was supposedly an advanced course, and so we asked them for a show of hands as to how many of them had peristaltic pumps and how many of them had Venturi pumps on their machines. And 75% of them said they had peristaltic pumps. And then we asked them how many of them were using the Bausch & Lomb machine. And 60% of them said they were using a Bausch & Lomb machine, which is almost always got a Venturi pump on it. So they didn't even know which pump they were using.
That's
Yes,
Richard, I mean, I just wanted to ask a question. So we
Hmm.
talk about how does the phaco power work, phaco modulations. You spoke about the jackhammer effect, the cavitation, and the fluid and the mechanical effect. Now the
Yeah.
Alcon, the Unity 4D. I
Yes.
mean, see, what is working here? Is it the cavitation that is working, or it is
No, it's not.
it
It's
is jackhammer?
the actual physical movement of the phaco tip which is doing it. But the same way that with the torsional, it was the side-to-side movement with the curved
Yeah.
needle that was emulsifying the nucleus. But the amount of cavitation that was actually taking place then was almost non-existent. Jaime Zacharias did a very nice laboratory study where he showed that even at 100% power with the full-on torsional phaco, there was almost no cavitation at all in the way of bubbles. Not the way that you would see if you did that with longitudinal phaco at 100%, you would see a lot of cavitation bubbles. So the new movement, the sort of cloverleaf movement that you get with the new Unity is the effect that is actually breaking up the nucleus more efficiently.
Okay.
But you always have the option of switching off torsional or OSIL with any of these newer machines.
Sure.
Yeah, and stick to straight longitudinal as well.
Well, what I found worked really well with a brunescent cataract was to start off with a quick burst of longitudinal followed by torsional, because you would get that first burst to get into the nucleus, and then the torsional would be better for actually breaking it up once you got there while you were holding it to do your chopping. And you could hear this sort of noise, a bit like sort of galumpa, 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 as it was chewing up the nucleus. I would set the longitudinal at about 40%, and then have the torsional at about 70 or 80%. And that seemed to be an efficient way of removing the nucleus using both modules. But I think, I mean, I will not get an opportunity to use the Unity machine because I'm no longer long doing surgery now. I'm too old for that sort of thing. But you guys will get to use it. And I believe from the people who have used it, that it does have some significant advantage for breaking up dense nuclei.
Yeah, see, as Sai was mentioning that, when to use longitudinal and when not to use OSIL. I feel that, like Richard was mentioning, for hard cataracts, Ozil cuts like fun. However hard it is, it really cuts as well as the negative from other machines. But when it comes to chopping, that time it doesn't give a very good hold. So I invariably switch off my Ozil, move on to longitudinal, and then chop, and then for fragment consumption, and again come back to Ozil. So this combination has given me very good results for, particularly for brunescent cataracts or even harder nuclear cataracts.
Okay, excellent, sir. I think even for very soft cataracts, when you are trying to do a stop and chop, when you want to make a really small trench, I think the longitudinal works well, and you make a really small trench and then divide the nucleus. So I think that can also be a added point here. So, do we have any more questions? We don't have any in the comments. So I think that way we come to the end of the session. And I would really thank Dr.
Can you
Richard
take a
Packard
picture?
for...
Screenshot.
Yes, sir. Yeah. Yes, sir.
I'll do that. I'll do that, honestly. I'll do that.
Okay, sir. Yes, sir. Yes.
Yes. 3, 2, 1. All smile. Thank you.
Right.
So I would like to... yes, sir. Yeah, I would like to thank Dr. Richard Packard for accepting our invitation for today's KSOS International Webinar talk. I would like to thank Dr. Sai Kumar and Dr. Arup for being our expert panel. And thank you to Dr. Rajiv Suparan for having us all here. And thank you, Dr. Sujit Naina, for having me as a moderator for this session. And thank you to all the audience who have joined us today for this beautiful session. I think we have a lot of points, right from history to practical tips of how to manage the intumescent cataract, and also an insight in learning fluidics and understanding it when we are applying it for phacoinvestigation. Thank you so much, sir. And thank you, everyone.
Thank you. Thank you, Anushree. Wonderfully moderated.
Thank you, Richard. Hope you will be available for some more programs in the times to come.
He just left, sir.
He has left. Okay.
Okay.
Thank you.
Okay.
Right. Thank you all. Thank you. Thank you, Anushree.
I went